I just wanted to begin by telling you that about 3 days ago, this week's New England Journal of Medicine came out. And there was an article in there that was so inspiring, I just wanted to share it with the group. A 22-year-old lady got a disease that most of us have never heard of or seen called lymphangiomyomatosis, a very aggressive, slowly progressive, fatal disease. And this young lady and her mother decided that they were going to do something about it. And they made an advocacy organization. They inspired research in this field. They discovered that it wasn't really benign, but it was actually malignant, as turned out to be the case with carcinoid tumors. They found out that the cells were driven to grow by Mtor, and Mtor inhibitors could be used to treat the disease, again, like neuroendocrine tumors. And they found that sirolimus, which is closely related to everolimus, that many of you have been treated with or heard about for treating neuroendocrine tumors, is highly effective in this disease. And the article was written in New England Journal showing the amazing effectiveness of this Mtor inhibitor in treating the cancer, and an accompanying editorial saying that this research wouldn't have happened if it weren't for the fact that the inspiration, support, and encouragement of patients has made it possible. And I think the analogy to what we're dealing with here in fighting rare neuroendocrine tumors is striking, and I just think it was very timely that it just showed up 3 days ago. Okay, it's my honor and privilege to be part of the group speaking with you today and share some thoughts with you about what's now new and next in treating neuroendocrine tumors. The most important thing that's happening now that's really revolutionizing the treatment of neuroendocrine tumors is the realization that this is a very, very complex group of illnesses that require the interactions of multiple specialists in medical oncology, endocrinology, radiation oncology, cardiology, gastroenterology, pathology, interventional radiology, diagnostic radiology, nuclear medicine, various surgical specialties, and all of us working together with many other specialists needed in certain cases, but having to work as a comprehensive team. And as you can see, we have a panel today with myself from medical oncology, Dr. Waltering from surgery, Dr. Warner, originally gastroenterology, all having different backgrounds, all working together and all trying to fight this disease. First, I'm going to talk about what's new and exciting in finding primary tumors and identifying sites of metastasis. This is a little piece of somebody's small intestine with little carcinoid tumors. They're so small that if you were to do a CAT scan, an MRI scan, an X-ray of an abdomen, you would not see anything wrong. Yet, these carcinoid tumors are sitting there growing inside the intestine. And they're very difficult to find. You do a colonoscopy, you don't see them because they're not in the colon, they're in the small intestine. You do a gastroscopy, you don't see them again because they're in the small intestine. So what do? There's a technique called double balloon push enteroscopy, or double balloon push endoscopy. This utilizes a technique where you have a balloon to stop the liquid contents of the small intestine from flowing into the observation area, both above and below an observation area, and then the entire tube is passed through the small intestine. It can be done from below through a colonoscope. It can be done above through an upper GI enteroscope. We've had a lot of experience at Cedars-Sinai doing this and can usually find a primary tumor or tumors in the small intestine that otherwise can't be seen. It's a beautiful technique. You could actually do biopsies, cauterize, the kinds of things you do with colonoscopy can be done with this directly, and you can actually get a specimen. So this is really an excellent diagnostic technique. The wireless capsule endoscopy is another way of looking at the small intestine. You swallow a pill that basically has an underwater digital camera with a radio transmitter, strobe flash, battery pack, everything you want in the size of a small pill. It goes through the intestine, taking about 2 pictures a second and transmitting them to an external memory. You can upload it into your computer and just play it like a movie, and you can find little tumors. It's a very nice way of finding tumors in the small intestine. It's certainly better than many other available techniques. And however, unlike the double balloon enteroscopy, you cannot do biopsies. And in some cases, if the tumor is south and the camera is pointing north, you may miss it as it goes by. Another way of looking at neuroendocrine tumors that are hard to find is endoscopic ultrasound. Endoscopic ultrasound can be done through the wall of the stomach and can see little tumors that are in the pancreas. You could find tumors that otherwise you might not see, or things that are unclear as to what they are on an MRI or CT, and you can see them more clearly and biopsy them. And also endoscopic ultrasound can be used sometimes to biopsy nearby liver lesions, and it's a very convenient technique. Endoscopic techniques are also used in evaluating carcinoid tumors of the rectum. CT enterography is another way of looking at the small intestine. It's a little bit like virtual colonoscopy, where you can do a CT scan that looks at the colon. You can do a CT scan that's designed to look at the small intestine, and sometimes can find little tumors that you wouldn't see on other imaging techniques. Again, you can't do biopsies with this type of technique, and it's not quite as accurate as a double balloon endoscopy, but in certain individuals where that type of technique is not feasible or practical, or there are many other reasons why this would be a better way to look. It's another way of analyzing. Okay, so that's some of the techniques that are new and current and coming up in diagnosing the primary. In terms of looking at metastases, we have a few things as well. An MRI scan in skilled hands is actually a very sophisticated way of finding liver metastases and small abdominal metastases. It should be done ideally with contrast, with gadolinium, and there's a new contrast agent called Eovist, which is also really excellent for looking at small liver metastases and is now being utilized in many centers. If a CAT scan is done, the best type of CAT scan is called a triple phase CAT scan, where you can look at the blood with the contrast inside when it's going in the artery and the vein and the portal vein, and you can see liver metastases with either the triple phase CAT scan or the MRI in up to 95% of people that have liver metastases. The Octreotide scan with tomographic imaging called SPECT and delayed imaging after several days can detect a high percentage of metastases. It's not a substitute for MRI or CT, however. CTs and MRIs have higher resolution. So if you're trying to follow somebody's course and see how tumors are doing, you're better off with the MRI or CT for staging of new patients, for determining if somatostatin receptors are positive, and it would be appropriate for appropriate situation for high-dose therapy with radionuclide therapy, which we'll be talking about later, or other special reasons the Octreotide scan can be used as needed. There are newer types of PET scans. The most common kind of PET scan that is done in America is called an FDG PET scan. It's done with a glucose type molecule, which is radioactively labeled with fluorine-18. This kind of PET scan detects metabolism of cells. The faster the cells are metabolizing, growing, using sugar, the stronger they will be on PET scan. This has turned out to be an excellent way of visualizing tumors, since most cancer has a higher metabolism than surrounding cells. But neuroendocrine tumors often have a low metabolism, divide slowly, and metabolize sugar slowly, and the PET scan may be negative even in the presence of metastatic disease, or only very weakly positive. But new types of PET scanning technologies are coming out. There's a fluorine-18 fluoridopa PET, which can pick up small neuroendocrine tumors. There's a fluorine-18 fluorohydroxyphenylalanine PET. In Europe, they're using carbon-11 5-hydroxytryptophan PET scanning with just extraordinarily good results, and gallium-68 DOTATOC PET scanning. These are means of using not just an Octreotide scan where the Octreotide is radio-labeled and sticks to the cancer, but actually to have the Octreotide combined with a PET scan isotope, so you can do a PET CAT, not based on metabolism of sugar, but based on the presence of somatostatin receptors. So these are all turning out to be important new coming technologies. In terms of treating cancer, we have also developed new ideas about how to approach this. In the past, the most common thing to do was to do very little, the so-called watch and wait. The rationale being the tumors are slow growing and incurable, so why cause trouble by treating these things? Surgery or other treatments can be risky and deteriorate from quality of life, but when you do this, the 5-year survival is only 20 to 30%, and this has not turned out to be very effective. We have much, much better. So this wait and see, watch and wait type of approach that was a standard of care in the past is not generally a standard of care now, and is really only even considered in people that are not candidates for any type of medical therapy at all because of overwhelming comorbid problems. So what do we do now? Surgery, number one, to remove the primary tumor and metastasis whenever possible, and I won't say more about that since we have Dr. Woltering here, who's the master of that field. Regional therapy of liver tumors using radioactive particle embolization, radiofrequency ablation, where the tumors can be annihilated with microwave energy, or chemoembolization with chemotherapy trapped in liver tumors for inoperable metastasis. There's also the possibility of systemic therapy using somatostatin analogs. We'll be talking about all these treatments in more detail very soon, using targeted biologic agents or chemotherapy, and also the possibility of peptide receptor radiotherapy or peptide receptor radionuclide therapy, as it's called, to target neuroendocrine tumors. So now we'll talk in detail about some of these options. When surgery is done, remove tumors from the liver, abdominal cavity, intestines, aggressively remove tumors even if it requires resection of parts of organs or blood vessels to do it. Reduce the cancer center by 90% is the goal. At the time a surgeon is in for metastatic disease, take out the gallbladder to prevent gallstones forming from octreotide, and also to prevent the gallbladder from getting injured by radioembolization or chemoembolization, since the artery to the gallbladder can come off the artery to the liver. And to take out the primary tumor to prevent bowel obstruction, prevent other complications of growing local tumor, and to prevent new metastases from spreading into the liver. We mentioned radiofrequency ablation, about one of the treatments for treating liver metastases. This is particularly good if the metastases are not very large. They should be ideally less than 4 centimeters in diameter, and there should be a limited number of such metastases to treat, since you can't, do hundreds of metastases in this type of a fashion. It's for a limited number of metastases. The probe is inserted into the liver metastasis at surgery, and then can be done under CT guidance without surgery. And after this needle with probe is inserted into the tumor, microwave energy can be administered. The tumor can be obliterated by local heat inside the tumor, and the surrounding area protected quite well. So you could end up with a dead tumor in a situation where surgery may not be the best way to do it. We can also treat liver metastases by embolization. We can take advantage of the fact that carcinoid metastases and neuroendocrine tumor metastases in liver get most of their blood supply from the hepatic artery, and most normal liver cells get most of their blood supply through the portal vein. So because of that fact that there's a double blood supply in the liver, and one of them more selectively goes to tumors, we can block off that blood supply that goes into the tumors, and we can put either radiation or chemotherapy into the artery that goes to the tumor. Radioembolization is done with yttrium-90 microspheres that are injected into the hepatic artery under fluoroscopic guidance and can selectively kill liver metastases in that way. In this paper, which was published by Kennedy et al. 3 years ago, 148 patients were treated with this type of radioembolization. Approximately 60% of the patients had a major anti-cancer response, with at least half of the cancer dying as a result. Only 3% had a complete remission, but most patients had an excellent response, and only 5% of patients were so resistant that the cancer just kept going. It really worked in most people very, very well. The average survival was 70 months, but survival is a sort of changing figure when we're talking about a disease that is a chronic condition and we have ongoing new therapies that keep coming along, and if one thing doesn't work, we use another thing. The results are comparable to those achieved with hepatic artery chemoembolization, also known as HACE, but hepatic artery chemoembolization typically has more acute toxicity. Radioembolization is done as an outpatient, and people don't get as sick as they do with chemoembolization. Chemoembolization, if it's done carefully, is generally well tolerated, but does require hospitalization for at least a day, and people get more pain and nausea and what's called post-embolization syndrome. And these good results with radioembolization were seen even when there was a fair amount of cancer previously in the liver or people had previous therapies. But one previous therapy that I should mention that does not make a very favorable situation for radioembolization is previous hepatic artery chemoembolization. If you've had previous hepatic artery chemoembolization, sometimes you could have more chemoembolization, sometimes you can have surgery or systemic therapy, but generally it's not a good idea to do radioembolization after chemoembolization because of changes to the small blood vessels that happen from chemoembolization. Okay, so to talk a little bit more about chemoembolization, it's an excellent way of destroying tumor. The average survival in certain centers where patients are treated in an aggressive fashion with multimodality therapy, including chemoembolization and surgery and somatostatin analogs like Octreotide and other therapies, survival can be over 10 years. It really does make a major difference in cytoreduction of cancer. And we mentioned the post-embolization syndrome, where people feel bad sometimes for a couple of days after the treatment, but generally relatively well tolerated. Really serious complications like infection or liver failure or death are very rare, but with any aggressive procedure like surgery or chemoembolization, there are rare patients who do get into troubles. Radiotherapy for carcinoid tumors with traditional types of radiation therapy is generally not something we think about very quickly, since these tumors don't respond very well to conventional doses of radiation. But radiation therapy shouldn't be forgotten as a treatment. It still can be used in treating bone metastases and unresectable carcinoids in the larynx, or sometimes palliating lung or thymic carcinoids. But the new and exciting thing happening in the field of external beam radiation is what's called radiosurgery. Having radiation coming from multiple different directions at the same time, all to focus on one spot. And with this type of radiation being directed by amazingly powerful computer systems that can pinpoint radiation down to millimeters, and can even be done with little implanted LoJacks in the tumor to tell the radiation beam where it's going, called fiducials. This type of procedure can actually radiate a tumor that would otherwise be inoperable in the middle of a liver or other similar situations, and pinpointed radiation is really starting to become an important additional modality in treating metastases. Also, brain metastases, spine metastases, where you have to have very precise targeting, yet the tumor be given an enormously high dose, so even a relatively radio-resistant tumor like a neuroendocrine tumor or carcinoid can be treated. Okay? Now, the next thing I'm going to talk about a little bit are somatostatin analog therapies. We talk about this all the time, but a lot of people still are confused about what it's all about, so I'll just review a bit. What is somatostatin? Somatostatin is a natural hormone in the body which stops the growth and hormone secretion of neuroendocrine cells. It's the turnoff. You eat a chocolate bar, your blood sugar starts going up, your insulin starts rising to lower the sugar gets down to where it should be, and somatostatin comes along and shuts off the insulin. This is a negative effect type hormone, has a normal effect in the body, but can be utilized in actually treating problems with neuroendocrine tumors. It's destroyed in the body within minutes, making it highly impractical to use as a drug. So along comes somatostatin analogs, which are slight derivatives of the original somatostatin molecule, slight chemical modifications that can make it stable for hours or even weeks. And the long-acting formulations most typically administered once every 4 weeks, but it varies whether It's a couple of weeks or a couple of months, depending on the formulation. So these modifications are called somatostatin analogs. The most commonly used one is octreotide, the brand Sandostatin, familiar to many of you, and octreotide LAR have been the mainstay for a long time in treating carcinoid syndrome, the flushing, diarrhea, wheezing, and other complications that can happen from having high serotonin production by carcinoid tumors. They can also stop hormone secretion by other tumors, for example, VIP production by pancreatic neuroendocrine tumors that causes bad diarrhea. We can stop these kinds of hormone productions, and they're highly effective for this purpose. But what has also turned up just recently and is now, I think, influencing approaches to therapy is using octreotide not just for treating diarrhea and flushing and other symptoms, but using octreotide to treat cancer. Because it turns out that octreotide not only stops hormone production by neuroendocrine cells, but it actually stops the neuroendocrine cells and makes them stop growing and dividing and being so active. So a large study was done in Europe known as the PROMID study. 85 patients with mid-gut carcinoids were randomized to octreotide LAR, 30 milligram injection every month, versus placebo injection every month. And the goal of the treatment was prolongation of what we call progression-free survival. That means how effective is this medicine in stopping cancer growth. The average time to cancer progression was 14 months when people got octreotide LAR, was 6 months with placebo. At 6 months, when people had octreotide, 67% of people were still stable, but when they didn't get octreotide LAR, they got placebo, 37% were stable. In addition, they saw that in this population, people that had the more slow-growing tumors and were treated with the octreotide LAR, people with low-volume disease, often the cancer would remain stable for years. And we've all seen people where octreotide actually stopped progressive cancer from growing and kept it from growing for many, many years, sometimes even 5, 10 or more years. These numbers I'm showing you now are not individual patients, but the population average. So some new somatostatin analogs now are coming along and worthy of discussion, in addition to the standard, which is, of course, octreotide. Lanreotide autogel is a new substance to use. It's a subcutaneous sustained release formulation that can be given once every 4 weeks subcutaneously, which is a little bit more user-friendly than a deep intramuscular injection, which is needed for octreotide. 80 days after administration, 80% of the drug is released into the circulation. So it very, very slowly leaks out into the blood. When you're given one dose every 4 weeks, you can maintain a constant therapeutic blood level. It's a very, very interesting drug, this lanreotide autogel. It's made by just 2 ingredients, lanreotide and water. It's put under enormous pressure, and when that happens, the drug assembles itself into these little nanotubes, and the lanreotide will leak out from those nanotubes in a continuous way, maintaining a steady blood level for a long time. So to evaluate this, there are 2 major national trials going on, I should say international trials, using lanreotide autogel versus placebo. The first is in non-functioning tumors of the carcinoid neuroendocrine type, to evaluate, again, progression-free survival and quality of life. The study designed for 200 patients, and the trial is nearly complete. Analysis hasn't been done yet, but hopefully it will be established as another very good treatment. Right now, lanreotide is actually FDA approved for treatment of special circumstances in pituitary tumors, so it is on the market, depending on insurance companies and that sort of thing. It may or may not be allowed for treating neuroendocrine patients not on clinical trial. But it's investigational for neuroendocrine tumors at the present time. The second major trial of lanreotide in neuroendocrine tumors is using the drug in people with carcinoid syndrome, flushing, wheezing. who have pathologically proved carcinoid tumor, a positive octreotide scan, stable cancer before going on the trial, and the patients either never previously treated with octreotide or other somatostatin analog, or people that have been responsive to conventional doses. So those studies are ongoing. Another type of somatostatin analog with ongoing and very exciting clinical trials is Pasireotide. There's a typo here, it's P-A-S-I-R, Pasireotide. This is a somatostatin analog that has improved binding to the neuroendocrine cells. The binding of somatostatin analogs to neuroendocrine cells happens at a place called a somatostatin receptor. And Pasireotide sticks to more parts of the somatostatin receptor and sticks more tightly than octreotide. 30 to 40-fold higher binding affinity to several of these parts of the somatostatin receptor, and because of this appears to have advantages. A phase 1 randomized trial was done with the medication in carcinoid syndrome. It proved to be well tolerated. GI problems were occasional, as were injection site reactions, fatigue, which were very similar to the side effects of octreotide. In fact, the side effect profile is almost identical. Octreotide can also cause an elevation of blood sugar. Pasireotide does as well, but the blood sugar elevation in Pasireotide may be a bit more than with octreotide, and there are some patients who either have diabetes or pre-diabetes and sometimes need to have medications for lowering blood sugar. Most people, the side effect profile is so similar to octreotide you can't tell the difference. This is turning out to be a promising treatment for carcinoid syndrome, generally well tolerated. Injection site reaction, fatigue, and hyperglycemia, as I said, at these 3 dose levels. A large randomized international trial with Pasireotide LAR versus octreotide is going on right now. A very important clinical trial that is now being done. Everybody in this trial gets the option of having Pasireotide. Half of the people get it on day 1 and half of the people get it at time of progression. Patients who go on this study have inadequate control of diarrhea and or flushing from carcinoid syndrome with previous somatostatin analog therapy. They're randomized between the 2 treatment arms, Pasireotide 60 milligrams or higher dose octreotide. This higher dose octreotide is a 40 milligram dose of octreotide given in 1 injection. So instead of having the usual situation to require 2 injections for a dose as high as 40 milligrams, this is accomplished with 1 injection by a unique formulation. Okay, and if somebody is randomized to the octreotide arm and does not respond well, then they are offered Pasireotide. So everybody has the opportunity of having Pasireotide, half of the people on day 1 and half of the people at time of progression. Another study being done right now is Pasireotide in rare pancreatic neuroendocrine tumors. These are the neuroendocrine tumors of the pancreas that manufacture insulin, gastrin, VIP, or glucagon. These are not the most common kinds of neuroendocrine tumors, but those of us who treat neuroendocrine tumors see lots of them. And also this is being used now in treating tumors that produce ACTH as part of the same clinical trial. Pasireotide 60 milligrams IM every 4 weeks. This is not a randomized trial. Everybody who goes on study who has one of these conditions is given the opportunity of having Pasireotide up front. Those are the most important highlights of the current somatostatin analog trials that I wanted to mention. Chemotherapy for neuroendocrine tumors usually does not cause a major reduction in tumor size. It's what we call a low response rate to chemotherapy, and for that reason is usually not the first thing we do in treating neuroendocrine tumors. But despite the low response rate, the prolongation of life the prolongation of progression-free survival, the ability to keep the cancer from growing, can be helped with chemotherapy, and that can in turn impact quality of life in a favorable way if it's used carefully so the side effects of the chemotherapy aren't worse than the side effects of the disease. The more metabolically active types of carcinoid and neuroendocrine tumor, which on pathology reports have words like intermediate grade, moderately differentiated, atypical, high Ki67, these kinds of carcinoid tumors respond much better to chemotherapy with major tumor shrinkage than the so-called well-differentiated low-grade type neuroendocrine tumors. The drugs that are being used for neuroendocrine tumors are most commonly 5-FU, streptozotocin, capecitabine, also known as Xeloda, temozolomide, also known as Temodor, and a combination of capecitabine and Temodor, dacarbazine, which is also called DTIC, and doxorubicin. Platinum drugs and etoposide are usually used in the poorly differentiated or intermediate differentiated, sometimes, neuroendocrine tumors. And as a general principle, pancreatic neuroendocrine tumors respond better to chemotherapy than other types of neuroendocrine tumors. Even when they are the well-differentiated type, there's something a little bit better in response to the pancreatic tumors. Targeted biologic therapies are what is most exciting right now in the area of systemic treatment with medicine. The unique chemical makeup of neuroendocrine cells make them ideal for targeted therapy. Neuroendocrine tumors have increased blood vessels and substances that stimulate blood vessel growth, making treatments that target angiogenesis, that target blood vessels around the tumor, stimulating them to have the blood supply for growth, is a fertile area of investigation. The cell membranes of neuroendocrine tumors have increased tyrosine kinase growth factor receptors, allowing targeted therapies to be used. And, for example, sunitinib or Sutent, which was mentioned earlier today, is an important member of that family. Pazotinib, another one that's being investigated in neuroendocrine tumors, and there are several others that are in that family, can be used. There also are certain genes involved in maintaining the malignant state that are overactive in neuroendocrine tumors, and now we're learning about how to target some of these molecular targets. Mtor, a molecular target for treating neuroendocrine tumors, an enzyme that's located in every cell in the body, but in neuroendocrine cancers is often found in higher amounts and tends to drive the neuroendocrine tumors as a central regulator of assimilation of growth factors and nutrients, and is involved in cell survival and growth and development and cell reproduction. It's really a central enzyme. And just as I mentioned, another very rare malignancy, which is driven by Mtor, that was recently found, it was published last week. There's some exciting information about using Mtor inhibition in neuroendocrine tumors, which has also recently been published in New England Journal of Medicine and presented in other venues. The first of these is the phase 3 randomized trial of everolimus, also known as RAD-001, or the brand name Afinitor, versus placebo in advanced pancreatic neuroendocrine tumors, which has been known by the acronym RADIANT-3. In this trial, advanced low or intermediate pancreatic neuroendocrine tumors were treated. It was determined what the disease progression rate was in the first 12 months, measurable disease by so-called RECIST criteria, which is a standardized way of determining how the tumors are shrinking. And these patients could have had other treatments before they went on the study. The conclusion of this study is that everolimus prolongs the average period of disease control. That's what they mean by progression-free survival. It's the same type of endpoint that we've been talking about for all of these scientific studies of treatments for neuroendocrine tumors, from 4.6 months to 11 months. very similar to what we saw actually in the PROMID study with somatostatin analogs. But here we're talking about a population of patients that already had progression after somatostatin analogs and need something more in many cases, or at least provides another modality in patients who either can't have or haven't had somatostatin analogs yet. A 65% reduction in risk of tumor progression, and was a very well-tolerated oral pill for most people. And it was felt that this is becoming a standard of care for progressive advanced pancreatic neuroendocrine cancer. It was recommended to the FDA that this be approved as a standard treatment for treatment of pancreatic neuroendocrine cancer based on this study and the publication of this study in New England Journal of Medicine approximately a month ago. And I would expect that we are going to be seeing FDA approval for this in the near future, I would hope. The other major randomized trial that you have maybe heard about or will be hearing about is the randomized phase 3 trial for treating carcinoid tumors. These are people with tumors other than pancreatic neuroendocrine tumors. Let me just go to the conclusions on this trial is that the everolimus plus octreotide group, compared to the octreotide group, had a 5.1 month additional period of cancer control, prolongation of disease-free survival, again comparable to what we see with other kinds of treatments. The placebo group was not really a placebo group, it was a octreotide group. This was a different study than the pancreatic study. The pancreatic study was everolimus versus placebo. The carcinoid trial is everolimus plus octreotide versus plain octreotide alone. Okay? Octreotide alone has anti-cancer activity as well. And it may be that the difference between the two arms of the study was a little bit less marked than it would have been as a result of that. In any case, these were the findings. And I think that we're going to see more studies and more use of everolimus and other types of neuroendocrine tumors. And for pancreatic neuroendocrine tumors, I think it's been very clearly established as a upcoming standard of treatment. There's clearly an unmet need for more and better treatments. I should also mention before we leave these Mtor inhibitors that Mtor inhibitors can be combined with other things quite effectively. They can be combined with chemotherapy and have a synergistic response. They can be combined with octreotide, Octreotide, and other somatostatin analogs and have a synergistic response, and be combined with certain other biologic agents with a synergistic response. And clinical trials of these types of things are going on, and even trials to optimize the dose of Octreotide in very high doses, which may have even more potent anti-cancer effects, are also going on. I'm trying to move along a little bit so we have time for questions as well. The next drug to talk about a little bit is the anti-angiogenic drug that attacks tumor blood vessels, known as bevacizumab, or the brand Avastin. It's a monoclonal antibody to VEGF that Dr. Wolin will be talking to you about, and it blocks this inducer of blood vessels. It can cause some side effects in some individuals, including elevation of blood pressure, some difficulties with wound healing, bleeding, or sometimes clotting because of its effect on blood vessels. And in neuroendocrine tumors, as a single drug, it has about a 24% response rate, but this may be higher in certain combinations. There's a combination of bevacizumab plus cytotoxic chemotherapy with 5-FU and oxaliplatin and leucovorin, known as Folfox, which has turned out to be effective, although it's a more complex regimen. and one with capecitabine or Xeloda, which has also been used, and bevacizumab is a part of both of those combinations. There is a large ongoing randomized trial right now being sponsored by the Southwest Cooperative Oncology Group, which is a phase 3 comparison of octreotide LAR plus interferon versus the same octreotide plus Avastin plus bevacizumab. And this will help to determine the role of bevacizumab in therapy of neuroendocrine tumors. We don't know yet whether interferon or bevacizumab is the better of the two. So far, they seem to be fairly close, and they both have anti-tumor activity. The tyrosine kinase inhibitor, which you'll be hearing the most about right now, is sunitinib in pancreatic neuroendocrine cancers. It blocks those molecular targets that are needed for growth and metastasis. It also works as an anti-angiogenic drug and other important cellular processes. In pancreatic neuroendocrine cancer, a randomized trial was done, which has recently been presented at international meetings and published in New England Journal of Medicine, in well-differentiated pancreatic tumors that had progressed and were randomized to either sunitinib, Sutent, pills on a daily basis in low dose, 37.5 milligrams a day, versus placebo. The average time to progression for people being treated was about 11 months when they got sunitinib and about 5.5 months with placebo. Again, comparable to the numbers we're seeing with other types of treatments. They can cause some side effects, including lowering of blood counts, elevation of blood pressure, and you can see some other side effects that are a little bit less common. What we don't know yet about these treatments is what is the best sequence. We know that they all have activity, they all can be used. Whether there's an advantage to using one before the other still is unclear. There are lots and lots of clinical trials, and it takes lots of clinical judgment on the parts of investigators to always keep the cancer under control with the lowest possible side effect profile, because after all, we're dealing with a chronic disease that people can live with, hopefully for many, many years, and you want to make sure that the treatments are working and at the same time not causing excessive toxicity. So we now have, instead of no drugs, we have a whole spectrum of drugs that can be used. They can be used sequentially, they can be used in combinations, and in certain situations available in clinical trial, certain situations available without clinical trial, but an enormous change in the last 5 to 10 years in what we have available for treating neuroendocrine cancer. The last thing I wanted to mention in what's new and coming and whatever is the use of peptide receptor radiotherapy, peptide receptor radionuclide therapy specifically, using somatostatin analogs like octreotide, combined with a radioactive isotope that shoots out a ray that penetrates only a very tiny distance and potentially can be given intravenously, go through the body, attach itself to the neuroendocrine cancers the same way that octreotide does normally, but after attaching to the neuroendocrine cancer, shoot out a little ray of radiation that will kill the cancer. So you're using the octreotide like a smart bomb, and you're using the radionuclide that's attached to it like a molecular nuclear weapon. Okay? So this is the concept of treating with this type of therapy. Lutetium-177 is widely used in Europe at this point and shoots out a so-called beta particle, a radioactive ray, that only goes for 2 millimeters before this electron, this beta particle, is completely absorbed. So if you have 20 cancers in your liver, for example, it'll give radiation into all of those 20 cancers, but the surrounding liver is not going to be receiving radiation. It just radiates the cancer and a 1 or 2 millimeter rim around it. And at the same time, it'll treat the metastases in bones or other places in the body. So it has, it's a very exciting modality with a lot of potential. In this particular study published from the group in Rotterdam by Kwekeboom and his group, they treated a large number of patients. Altogether in Europe, well over 1,000 patients have been treated, and they see major responses in a small number of patients, but they see failure to progress in the majority, and it is another means of keeping cancer under control. The average time till progression occurred in the whole population was about 40 months, and after that, sometimes the treatments can be repeated. If kidney protective agents are used, major side effects are few, even though it can have the potential of injuring kidneys. It has the potential of injuring bone marrow. There's a rare person who's developed pre-leukemic or leukemic conditions as a result of the treatment. But in general, it's well tolerated and gives us another type of therapy. In America, a phase 1 trial is currently going on in Houston, as you've heard, and hopefully within the next 6 to 12 months, there will be a major university-based trial in several centers in America, and this therapy will become more widely available on clinical trial. The last thing I wanted to mention was a new development in treatment of side effects. There's a drug which stops the production of serotonin by carcinoid tumors. It inhibits an enzyme that is necessary to manufacture serotonin, and as a result can stop the watery diarrhea from carcinoid that cannot be adequately controlled sometimes with octreotide. So if somebody has watery diarrhea that can't be controlled, we have a variety of medical treatments that can be used. We can use higher doses of octreotide and measure blood levels of octreotide and make sure it's right, which I'm sure Dr. Wolin will mention as well. And we can do other things. We can use Pazeriotide, which can sometimes stop the diarrhea that doesn't stop with octreotide. But now one of the things we can do is to add a medicine called LX1032, which is this anti-serotonin production drug. It's a pill, very few side effects, and it's available now on clinical trial and provides still another modality. And very importantly, does not cross the so-called blood-brain barrier that inhibits the medication from getting into the central nervous system, and by staying in the body and not going into the brain, it doesn't have a problem with depleting brain serotonin that can cause depression and other problems in the central nervous system. You certainly wouldn't want that to happen when you're using an anti-serotonin. So those were the major issues that I wanted to bring to your attention, and again, it's my honor and privilege to be here to speak with you today. Thank you.